something I'm interested in, but not particular. It's not an area that I am a particular expert in, so I welcome discussion. Unfortunately, Roberto isn't here. He actually is somewhat of an expert on neonatal morphine. So, well, we'll just see where we get. I have no disclosures. I wanted to start with just a little bit of history about where we've been in treating pain in neonates. And I think the story starts where before 1985, people truly believed that neonates did not feel pain. And so I think terrible things were done just for ignorance. And then in 1985, there was a landmark paper that was published that was basically the story of a preterm infant who had undergone PDA ligation without anesthesia. And it was very graphic and horrified people, rightly so. And then we come to the 1990s where narcotic infusions were regularly used for operative pain, and that practice kind of slid into the NICU, and so babies were starting to be treated for sedation with opioids in addition to being treated for pain, for postoperative pain. In 2000, the AAP and the Canadian AP issued a joint statement regarding neonatal pain management, saying that it should be the standard of care that babies be treated for pain in the same way that adults are treated for pain, basically. In 2004, there was the publication of the NeoPain trial, and I'll go into that in a little bit more detail later on in the talk. But basically, that was published that showed really not any significant differences in patients who were treated with morphine for sedation, for ventilation, compared to patients that were given placebo. At that same time, JCAHO mandated pain assessments and management in the neonatal intensive care units. So now it's mandated that we have BIP scores or PIP scores or whatever sorts of scores you use, but there needs to be regular documentation of the pain assessment for neonates. In 2005, there was a Cochrane review that concluded, as they 90% you said yesterday do, that there was insufficient evidence for routine use of opioids in mechanically ventilated babies. And then in 2009, really the majority of critically ill babies are exposed to sedatives at some point during their hospital stay. So there's really been quite a swing of this pendulum. So some of the questions that I had just as a practicing neonatologist is, what or who are we really treating? And I can tell you there's some days where I think that we're treating the nurses, not the babies. And there's some days where I think, no, we're doing the right thing and we really are treating the babies appropriately. So it depends. So what things have changed since the NeoPain study was published? And we looked at that in our unit. What are the risks of neonatal pain and stress? I think those need to be considered carefully. And also, what are the risks of drug treatment? And then, is there an interaction between pain and drug treatment? And then, are these drug treatments effective? So we're giving these drugs, do they make a difference to the babies, or is it all just downside? You've made the point over and over that it's a double-edged sword, and it's a really good point, because I think there's no free lunch for our treatments of babies. Everything that we do or don't do has a risk. And finally, are there effective alternatives for the management of neonatal pain and stress? So here we go. What are we treating? Well, there's many different kinds of pain. There's acute pain, such as is experienced with needle pokes, venipuncture, heel pokes, intubation, those sorts of things, suctioning. Postoperative pain, that's sort of the classic pain that we think about. But there's also inflammatory pain, visceral pain, neuropathic pain. And I think acutely, pain results in a massive energy expenditure. It's sort of the fight or flight response. But chronic pain, which I think is probably more akin to what most of our babies experience, basically results in a conservation of energy. There's passivity. You see a decreased oxygen consumption and decreased heart rate variability. So it's important to differentiate what kind of pain you're looking at or treating. The other thing to think about in preemies is what is the development of pain fibers and pain experience. And it's known that there is central descending inhibitory control is less well developed in preterm infants. There's also minimal myelination early on. And so the result of that is these babies have hyperalgesia or exaggerated pain response because they do experience pain, but the inhibition is decreased. They also have allodynia, so pain from things that aren't normally thought, like light touch. Things that aren't normally painful can be painful, and longer latency responses. And I think even up to 2 years old, that's true. We've all seen little toddlers fall down, and then it takes them a minute to figure out that they're hurt, right? They start crying like 60 seconds later. So that's even more exaggerated, I think, for preterm infants. So pain responses can be physiologic, biochemical, or behavioral, and there's some examples of all of these categories. So physiologic include heart rate, blood pressure, and oxygen saturations. Biochemical include things that you can measure in the blood, so catecholamines, cortisol release, lactate or glucose changes. And then there's the behavioral things that we look at when we do most of our bedside measurements of pain assessments. Unfortunately, when you're evaluating pain, things that are just normal for babies can look like pain. So this is a picture of a baby published by Sonny Anand that you could look at that face and say, oh, that baby's in pain. Or it could just be that baby has a dirty diaper. I mean, it's difficult sometimes to differentiate between what's truly pain in a baby and what's just, babies cry sometimes. So there are lots of different tools that have been published for assessing pain in babies. There's more than 40 of them. And most of them are evaluated for acute procedural pain. And they're evaluated for intra-individual variability, reliability, not necessarily for chronic pain or for discomfort. And they're also correlated with neuroendocrine markers, but they're not correlated with what we consider to be the gold standard, which is patient report. And obviously that's because babies can't tell us if they're in pain or not. So we're really limited, I think, in our ability to assess pain in these babies. So I've just got a few of the commonly used scores here. So the PIP score, the Premature Infant Pain Profile score, includes gestational age, behavioral state, heart rate, oxygen saturation, and facial expression in the scoring system. And they include things like this brow bulge and eye squeeze that you can see there. The BIP score, Behavioral Indicators of Infant Pain, combines facial and sleep-wake state with hand movements. The NPAS score, Neonatal Pain, Agitation, and Sedation Scale, includes crying, irritability, behavioral state, facial expression, tone, and vital signs, and there's a score of 1 to 3 or something for each one of these things. So there's a variety of different scoring systems that can be used. So next I wanted to just look at what's actually being done at this point in time, and I have 2 examples. So in our own unit at the University of Washington, we asked the question, since the neopain trial was published, have we changed our practice in the way that we use morphine to sedate babies that are ventilated? And our a priori hypothesis was that morphine use would go down. But it turns out that actually we haven't really changed our practice. So we looked at 678 patients, less than 1,500 grams. There were several excluded for a variety of reasons. So we ended up with 331 patients. And really, over time, our use of sedation has not really changed. And I think that's probably typical of many units across the country and the world. I also, with permission from Reese Clark, looked at some data for term babies with HIE. And so this is from the pediatrics, which is a large neonatal practice group in the United States. They collect data from all of their patients, so they've got this terrific database. And basically, they looked at all patients through 2010 that were admitted for cooling. And one of their data points was the use of sedation. And you can see here, these are separated by head cooling and whole body cooling. 75% of their patients were treated with whole body as opposed to head cooling. But a huge number of them were treated with sedation of some kind or another. And some of the patients received more than one sedative. So they received opioids plus benzodiazepines. So overall, I would say we're treating a lot of babies with sedation. So what are the short and long-term risks of pain and stress? So short-term stress can be a positive thing. It's a response that, the fight or flight response is there to help us get away from things that are dangerous. It can be beneficial, but it's clear that prolonged inescapable stress is actually harmful. And for babies, early neonatal stress can affect long-term learning. It can affect neurodevelopment, and also has deleterious effect on the immune system. And preterm infants in particular are clearly exposed to prolonged inescapable stress. So they're separated from their mother, they undergo multiple painful procedures, and I think one of the prominent researchers in the field is Ruth Grunow, and she's documented the hundreds of painful procedures that preterm infants undergo during their several months stay in the unit, and it's phenomenal. And, and she's also correlated that with long-term outcomes. So these babies are ventilated, they're gavage fed, sometimes they're hypothermic. So clearly, prolonged inescapable stress. And so we looked at this also in terms of what is the interaction of stress with morphine. And so we developed an animal model to try and model this. So we took, originally we started with rats because they're larger, and eventually we went down and looked at mice. So this is a picture of a mouse experiment in our lab where we take these mice pups and separate them from their peers and also from their mothers for 8 hours a day. They received daily weights. They got studied drug injections, so either saline or morphine. They got hyperoxia and hypoxia exposure. We were trying to simulate apnea here, where the babies get hypoxic and then hyperoxic as they get resuscitated from their apnea event. and then we gavage fed them with rodent milk substitute. So basically what we were trying to do here is recreate what happens to a preterm baby in the neonatal intensive care unit and measure how these babies respond. So we did a microarray experiment. So these animals were 9 days old at the time of sacrifice. They were treated from day 5 to 9, and then we extracted RNA from the hippocampus and looked at gene expression. And the treatment groups were, we had control groups that were kept with their mother. So these babies were not touched, were not interfered with in any way. We had mild stress groups that were either treated with saline or morphine. And the mild stress was just, we took them out and weighed them and gave them their injection twice a day. And that's actually quite stressful for a rodent. And then we had this severe stress group where they were kept away from their mothers for 8 hours with the protocol that I showed you. And so we thought that this would allow us to assess stress, in that we had control animals, the mildly stressed animals, and the severely stressed animals that were both treated with saline. So that would give us information about the effect of increasing stress. And then we had animals that were mildly stressed with morphine and mildly stressed, mild stress with saline and mild stress with morphine. So that would give us information about morphine in the context of mild stress and morphine in the context of severe stress on this side. So the results that we found were that there were clearly changes in gene families that corresponded to mild stress and to severe stress. So immune function was affected by stress, blood pressure and corticoid expression. Genes that had to do with cell maintenance also were affected by mild stress, which is sort of interesting. And severe stress affected neurodevelopment and inflammation. And then there were decreases in expression of cellular repair genes like telomere repair and DNA processing. So that was interesting. And then if you add morphine to the mix, we got changes in gene families that had to do with oxygen transport, mitochondrial membrane maintenance, and neurodevelopment. Decreases in gene families that had to do with cholesterol production, proteoglycan, and steroid synthesis. And then if you added severe stress with morphine, you got, again, separate gene families that were up or down regulated. So this is an example of what some of these studies look like. Again, each column is one animal, and each row is a gene within a gene set. And so the title of the gene set here is cellular stress response, ATP synthesis, electron transport, microtubule bundle formation, and dendrite development. So these are just some examples of some of the gene sets that we looked at. And here, this is severe stress with morphine. And you can see there's an upregulation of this set of genes here. Again, this is severe stress compared with severe stress morphine in all of these panels. And so there's clear differences in these groups of animals. And interestingly, there are some gene sets that are not affected by stress, not affected by morphine, but they're highly affected by both stress and morphine, so showing an interactive effect between stress and morphine. And this is an example of one of these gene sets. So it's a set called oxidative phosphorylation. And these three animals were controls. These three were mild stress morphine, mild stress saline, severe stress morphine. And you can see these genes are just super upregulated. And then the severe stress only showed a little bit of upregulation. So this sort of brings up more questions than answers, but it tells us that we have no idea what we're doing to these babies. I think at the very least, it tells us that. So what are the short and long-term risks of the drug treatments that we use? We have some experimental data to look at, and there's actually quite a bit of data on morphine exposure, both prenatal morphine and postnatal morphine. And it's been pretty clearly shown, at least in rodents, that morphine modulates the proliferation, survival, and differentiation of neural stem cells, neurons, and glia. And as a result of morphine exposure, you see decreased brain volume, neuronal density, and dendritic growth in animals as they grow up. So this is brief neonatal exposures and then looking at the animals long term. They also show decreased learning and locomotor activity. So that's a little bit scary. Conversely, if you block these opioid receptors, you get an increase in brain size, increase in dendritic arborization, and number of dendritic spines. So clearly, again, at least in rodents, opioids modulate cell proliferation in a receptor-specific, brain region, and cell type-specific manner. More data from experimental animals. The effects that you see are dose-dependent. And there's also an interaction with pain. So if you give animals morphine in the absence of pain or stress, you see certain responses. But if you're treating pain, not necessarily stress, but if you're treating pain, those responses aren't necessarily there. So here you see morphine or repetitive pain changes, so in the neonatal period, so day 1 to 7 in a rat, changes adult pain thresholds, locomotor behavior, and alcohol preference. But if you give morphine and repetitive pain, you don't see those effects. So maybe if we're treating neonates appropriately for pain, that's a good thing. But if you're treating them inappropriately, maybe it's not such a good thing. And clearly there's clinically adverse effects of these drugs. So respiratory depression, hypotension, for morphine in particular, there's histamine-induced bronchospasm, decreased GI motility, urinary retention, and I think likely altered brain development and function. So now I'm asking the question, are the drugs effective? So do they do what we are hoping that they will do? So there's many drugs that are used in the NICU, and I've categorized them as analgesics or anesthetics versus sedatives. So, so in the analgesic category, I think opioids are fairly commonly used. I think intensive care units vary as to whether they're morphine users or fentanyl users, but I think overall most units use some type of opioid in the management of pain and also sedation. Acetaminophen, ibuprofen also should be considered, and then there's lidocaine and EMLA that can be used. And then for sedatives, we have benzodiazepines as a category, so midazolam and lorazepam are commonly used, chlorohydrate and dexmedetomidine, and I'll talk a little bit about all of these. Well, not chlorohydrate, but so for how should we be using morphine if we're going to use it? So there's data from Ann Lin looking at what are considered analgesic plasma level concentrations after major surgery, and target levels are 10 to 20 micrograms per liter. Higher levels are needed if you want to produce sedation for mechanically ventilated neonates, because they don't, just covering pain doesn't actually sedate them. It only eliminates pain. So levels that we commonly see in human infants in the NICU, so giving a 50 microgram per kilo bolus, so that's fairly common, I think. The standard in our unit for a long time is giving 0.1 milligrams per kilo, so double this as a bolus. And then 10 to 30 micrograms per kilo per hour, I think, is not uncommon to be seen. So these sorts of doses result in steady state morphine levels of 200, so 10 times what the target plasma levels are for analgesia. Again, development is important to keep in mind when we're talking about drug metabolism. And morphine is metabolized in the liver by glucuronidation. And the two byproducts are morphine 6-glucuronide, which is, has very high analgesic potency. And the other metabolite is morphine 3-glucuronide, which turns out is an opioid antagonist, so counteracts the pain effects. And, oh, by the way, preterm infants have liver maturity. They make mostly the 3G product. And so the more morphine you give them, the more of this metabolite they make, which actually decreases the analgesic effect. I have to just give you a disclaimer. I use morphine and fentanyl as well. So it's, you know, it's just the, yeah, anyway, cognitive dissonance here going on. So fentanyl is about 100 times more potent than morphine. It's metabolized like this. It's excreted by the kidneys, and one benefit of fentanyl is that it has less histaminic effects than morphine does, so hypotension as a result of fentanyl is less common, but tachyphylaxis is more common, so the more you give, the more you have to give, basically. And then the other thing to keep in mind is the rigid chest syndrome. And Salvador, you were saying yesterday at 1 to 2 mics per kilo, you don't really see that. In our unit, we have seen it enough that our nurses are pretty scared of using it. We do use it for our rapid intubation, our rapid sequence intubation, but we definitely have seen it. So the NeoPain trial is probably the best trial that's, or largest trial that's been done in preemies to look at the use of morphine in our NICUs. So it was a randomized blinded trial of 16 units. They compared morphine, the 100 microgram per kilo bolus, plus an infusion at either 10, 20, or 30 micrograms per kilo per hour. They compared that with the use of placebo. And in addition, babies could be given open label morphine because people felt that it would be unethical to randomize patients to saline or morphine and not have the ability to give morphine if they thought the patients were experiencing pain. So morphine lowered the infant pain scores, but preemptive morphine did not reduce the frequency of severe IVH, PVL, or death. And open label morphine was associated with worse outcomes. And it turns out that whether you were randomized to the placebo group or the morphine group, about half the patients got additional morphine boluses. So no difference between groups. The other thing, in the secondary analyses of this study, there was no relationship between plasma morphine levels and response to ET suctioning, or in response to heel stick or other painful procedures that we commonly use in the NICU. And so Anand's comment about this was this not only calls into question the validity of these measures of pain, so are we measuring the right thing, but also that if we are measuring the right thing, does morphine do anything for these patients? So other secondary results, there was no reduction in chronic lung disease or in adverse pulmonary outcomes, and I think that's one of the reasons that we use morphine on ventilated babies is because we think, you know, it'll calm them down, allow us to ventilate them more effectively, and hopefully decrease the length of ventilator use. Higher doses were associated with longer lengths of ventilation, and worse pulmonary outcomes were associated with intermittent boluses. And finally, from Dr. Bellou, this was a meta-analysis of 13 studies on 1,500 infants. And they showed basically that opioid-treated infants showed lower PIP scores, but not clinically significant decreases in the PIP scores. I think that the decrease was by 1.7 points or something, which doesn't take you from, being in pain to not being in pain. It's just statistically significant. There was no difference in mortality, duration of mechanical ventilation, long or short-term neurodevelopmental outcomes. But clearly, the morphine-treated babies took longer to feed. So methadone is another drug that is sometimes used in the NICU. Frequently, patients treated with morphine are treated once babies have been on morphine for a long time and you're trying to get them off morphine, then methadone can be very useful. It blocks NMDA receptors and produces additive analgesia in addition to the opioid effects. It causes desensitization of the delta opioid receptors, and that helps reverse the tolerance that occurs with morphine. Pretty low cost, has a long half-life, but I think it can have some negative connotations because people think about methadone as an addict treatment. Although I have to say a lot of our babies are addicts, so it seems appropriate. But benzodiazepines are frequently used as sedatives in the unit. They cause not only sedation, but also amnesia, which makes me worry a little bit. If you forget, if you're treated with a benzodiazepine for a week or a month and you're developing neonate, what does that do to your synaptogenesis or brain development? I don't know. I worry about it, though. Also anxiolytic, muscle relaxant, and has anti-seizure effects. So effects are dose dependent. There's always the question of whether they work in neonates, and I talked a little bit yesterday about the GABA switch. So before 30 or 32 weeks, benzodiazepines can have an excitatory effect, and there's been many reports of these adverse idiosyncratic reactions to benzodiazepines. It may not be that idiosyncratic, it may just be a developmental effect, that you're actually just seeing the excitatory GABA response, which is appropriate for a baby before they've gone through this GABA switch, and GABA ergic effects are inhibitory, if that makes sense. So effects vary by dose and by the drug that's used. So diazepam, the dosing range generally is between 10 and 30 milligrams per kilo. In experimental models, again, it has been shown to cause apoptosis of neurons in the cortex and subcortical areas, also in the thalamus. And exposure can cause long-term changes in GABA receptors and neurosteroid levels. Same thing basically with midazolam. So in adults, there's some very interesting studies of hospitalized ICU patients. And it's been very clearly shown that the duration of acute brain dysfunction or dementia that occurs in the ICU correlates with long-term outcomes. So if you have ICU dementia, you're more likely to have long-term memory loss and decrease in executive function. And there's some very nice studies cited here that show that sedation contributes to the duration of dementia in the ICU, and benzodiazepines and narcotics in particular contribute to this ICU psychosis. And dexmedetomidine, which I talked about a little bit yesterday, actually was protective in these adults trials. And so people were very excited about the potential for this use in babies. So, sorry, Salvador, but this is my...
I agree.
Yes. So I think we have to be careful when we're using benzodiazepines in babies. And here's one study that compared placebo versus atropine plus placebo. This is for intubation, for rapid sequence intubation, versus atropine plus midazolam. And they stopped the study early because there was a higher need for CPR and desaturations in the babies that got the atropine. The midazolam. So dexmedetomidine is a selective alpha-adrenergic agonist. And again, there is a lot of excitement about this drug because it seemed to be very specific. The receptors are located in very specific spots as opposed to opioid receptors, which are present basically all over your brain. It provides sedation and causes less respiratory depression in adults. They can actually answer questions and interact very appropriately when they're being treated with low doses of Precedex, but they're pain-free and not anxious, so it seemed like a fabulous drug. Yeah, basically what I just said. But in babies, actually, I was a little bit concerned because at this last PAS meeting, a group of neuroscientists got together, and we talk every year about what are the new upcoming hot neuroprotective agents. And one of the drugs we talked about was dexmedetomidine, and several of us had done experiments in our various models of neonatal brain injury. And so Nikki Robertson has done some work in piglets looking at dexmedetomidine. Alistair Gunn has done work in fetal sheep, and we've done a little bit of work in non-human primates. And all of us had negative findings to report. So there was increased gliosis, increased CPR, increased just brain injury with this drug in neonates. So I think this is, again, one of those things where adult work may not be applicable to babies. So I think we need to proceed with caution. And I don't know about your units, but in our unit, dexmedetomidine use has slid down from the PICU, where it's used a fair amount, and now it's being used in our NICU patients. So I came back from PAS, I'm like, stop using the dexmedetomidine. We have no data, and the stuff that we have may be that it's harmful. So again, I think we can't forget using things like Tylenol. It really does help for pain. It's an anti-inflammatory COX inhibitor, and there are times when it's appropriate to use Tylenol in the NICU. We need to remember that its bioavailability is lower if you're using the rectal route, so higher doses need to be used. But again, like so many things, it's not really beneficial for procedural pain, heel sticks or circumcision. And EMLA, you know, if you have the time and you think about it, you can use EMLA. That's that cream that you put on under a patch, and you put it on 45 minutes before you want to do a venipuncture or something like that. It definitely does help. You have to think about it, though, and I'm not sure about its use in preterm infants. I've not seen anything about safety and efficacy in preterms. So finally, are there effective alternatives for the management of neonatal pain and stress? So kangaroo, I think kangaroo care is definitely makes both the babies and the moms or dads feel better. Some data to support that. Breastfeeding, always a good thing. Sweeties, I don't know if these are a good thing or not. These, we use them a lot. Turns out it's mediated through endogenous opiate release. So we may just be basically giving endogenous morphine when we use sweeties for these. And there is one paper that suggested that there was adverse neurodevelopmental outcomes if these are used frequently and repetitively, probably similar to the effects of morphine use. So another approach is just to be mindful about what we're doing to the babies and try and limit the number of painful procedures. And if we can't limit them, at least batch them. And, you know, creating a less stressful NICU environment involving parents as much as we can. I think we all try and do that, but there's certain things that we just have to do to take care of these babies. So what we can do here is somewhat limited. But we can swaddle and position and use music or soothing sounds. Our unit at Seattle Children's, our pain, we have pain consultants, and they actually use acupuncture in our babies now. They'll come in, and these babies who are, have been on these high morphine, benzodiazepine drips, they'll come in and they'll have little magnets in their ears and needles in them, and they're calm. It's amazing. I have no data, just anecdotal, but kind of interesting. Family-centered care and continued reevaluation of what we're doing. And I'm going to close with this. This is a table from Sonny Anand, who I think is the leader in this field. And basically, he cautions us to remember that pain in newborns is often unrecognized and undertreated, that neonates do feel pain, and analgesia should be prescribed when indicated during their medical care. If a procedure is painful in adults, it should be considered painful in newborns, even in preterm newborns. Compared with older age groups, newborns may experience greater sensitivity to pain and be more susceptible to long-term effects of painful stimulation. Adequate treatment of pain may be associated with decreased clinical complications and decreased mortality. Appropriate use of the environment is important. Sedation does not provide pain relief and may mask the neonate's response to pain. And that we as healthcare professionals have a responsibility to our babies to treat pain appropriately. And that we should all have written guidelines and protocols for the management of pain. So these are some pictures of where I come from. This is the University of Washington. We have an NICU in this building here that's primarily preemies. And then this is the Seattle Children's Hospital, which is a typical children's hospital that has all the babies are transported in. It's primary surgery babies, heart babies, complicated babies that no one else knows what to do with, and they all end up in this unit here. This is a picture of the city and the mountains that aren't so far away. So, thank you. Happy to take questions.
Do you have, I've seen in different units they use the hungry baby protocols. Do you ever use anything like that?
Haven't heard of that one.
Okay, that's good. You know, in some places where they have the babies NPO, for example, for a long time, they put them on, and I've seen this with reverse actually, to decrease their anxiety while they are NPO, and this is used a lot. I asked that based on so that's one question. And the other one, do you have a protocol for pain for babies that are going to have LPs?
We don't have a protocol for that. We have morphine guidelines, so it's very prescribed as to, so you start with a certain dose and you can redose with boluses every 15 minutes for pain. And this is mainly for post-op patients, but we use it for all babies. So you can give I think on your third dose of 0.025 micrograms per kilo, then you start a drip, and then you have to assess with the BIP score, and there's very strict criteria for going both up and down on the drugs. Because what we found in our unit is the babies go up and up and up, and no one ever turns them down. And so we made that an important piece of our pain management protocol. So if you haven't had, a score over a certain amount for a certain length of time, the drip goes down. So, and that guideline has been implemented. It's been in place for a year. We're still not using it consistently because it's a real culture change. And so, I mean, I think one of the important things about that timeline that I showed you on the first slide is that, you know, there has been this real shift in culture, and we've gone from not using these drugs at all in babies to like a lot of babies. Most babies actually get them, so I think it's important to treat pain. Don't get me wrong, but I think it's important to treat pain, not to just treat the babies for not pain. So.
For longterm too, we just use EMLA. It works very well.
Yeah. I think that's
because finally what is really painful
is the needle,
yes.
right?
And
Yeah.
it works very well.
Yeah. So we do that at Children's. We don't do that so much at the university. So you do that with the tiny babies as well?
But of course you put less cream. When you have a cream and you have a patch, we don't use that.
Yeah.
We use the cream and you put
Yeah, that's great. Because it's not like there's emergency LPs. You always know when you're going to do it.
You put the cream and then you use, you know the plastic?
Yeah.
So you use the plastic so you don't have something to fuse.
Oh,
Because
that's
when you
great.
use a
Yeah.
patch, you have the cream and then you have the plastic.
Yeah.
That hurts.
Yeah.
When you peel it off.
That's a great
So
idea.
you use the cream and you use the plastic, it works very well.
Terrific.
And no pain.
Well, I'll bring that home with me. That's great. It's really, yeah.
So do you have new data about ketamine?
Well, so there's several publications that are fairly recent about the use of different anesthetics on newborns, and I think I don't think the data are 100% solid, but I think it's looking very much like the repetitive anesthetic and longer duration of anesthetic is harmful for neurodevelopmental outcomes. There's data in monkeys showing very clearly that that's true. The data in humans are harder to come by because it's harder to control. So there's several twin studies now looking at one twin who is operated on, one, compared to the non-operated twins, or studies of babies who have had herniorrhaphies repaired prior to age 1 and looking at outcomes. But again, in babies who have 1 surgery versus 3 surgeries, the outcome for multiple surgeries is worse. But why were they getting multiple surgeries? I mean, those things are hard to control for. But I think the data are coming in that prior to the age of 3, if you can avoid an anesthetic, it's probably a good thing. Yeah. Other questions? Yeah.
You have any problems with using them,
No. I think the only thing is for EMLA, you do get vasoconstriction with EMLA, so sometimes, like if you're using it for venipuncture, it can be harder to actually be successful, and so you may need to poke more than once. So it's, but I think overall it's a good thing. You just have to think about it, and. Okay, I think lunch is probably. Oh, break. Okay. No, I was just thinking. I felt like I'd been up there a long time.